Okay, all right, we are back and really excited for the second panel. I see some faces on there. So our second panel today is on a very important issue, health policy and reimbursement trends. Today we have Dr. Deepa Kumaraiah, who's Senior VP of Service Lines and Chief Physician at NYP Medical Groups and at NYP, New York-Presbyterian. We have Melissa Schulman, who's Senior VP of Government Affairs at CVS Health, and Professor Michael Sparrow, our friend at the Mailman School of Public Health. Professor Sparrow is chair of the Health Policy and Management Program, also HPM, so sometimes we get a little confused, but we're lucky to have him. And all moderated by Jeff Jonas, who is the portfolio manager at Gabelli Funds. So just like last time, please put your questions in the Q&A box. We do look at them. We can't get to all of them, but we love seeing them. And over to you, Jeff. Looking forward to it.
Great. Well, thanks a lot for that introduction. And thanks again to the panelists who are giving generously of their time. You know, I think one of the things I've been most impressed about the healthcare system has been its speed and flexibility over the last 9 months or so. And one of the things I've seen change the most has been an acceleration in the shift of site of care, basically pulling procedures out of the hospital, either to free up beds or to just bring it closer to the patient in their home or in their community where they're more comfortable. So I guess the question first for Dr. Kumaraiah is, you know, have you seen this trend as well? Has it been positive or negative for you? And how has your organization responded?
Thank you, Jeff. We've most certainly seen this trend. And I think as you know, COVID will bring about or has brought about simply an acceleration of what was already happening in healthcare in terms of site of care. If I think about my perspective from a hospital system, something that we've been spending a lot of time in the recent weeks talking about is the emergency department. Most of our ERs are at 20 to 30% of previous capacity. Some of them may stay that way for a fair amount of time. And you wonder if, again, from an inpatient hospital perspective, we may be doing more tele and virtual urgent care for that percentage of the population that was always coming in. And that may be a fundamental shift in where people receive some of their urgent care. So from an ER inpatient perspective, we're seeing shift to care. I only anticipate when you think about operating rooms and in hospitals, cases that are seen as more elective, shifting very rapidly. You've seen a rise in ASCs, particularly around the orthopedic services, as they're shifting off the inpatient only list. And I think that's going to continue to happen more rapidly. So seeing joint ASCs pop up. I think shoulders are coming off the list next year. And again, I think for healthcare providers, we at New York-Presbyterian have been talking about sort of telehealth and virtual health options for the last 5 years. I would say we were an early mover in this space, though I can't tell you the number of people who said not possible. And within 3 days, their whole practice was shifted to a virtual model. And so, I'm recalling talking to a 60-year-old transplant surgeon who said to me, Deepa, this is never going to happen in my life. And calls me and said, you can't believe it. I saw 3 patients for the first time virtually, and it was amazing. If only he would look back at the last 5 years of me pushing him to think about his practice differently. So I think we're at a point where a lot of things are going to sort of shift in terms of how we think about our patients. I think monitoring, particularly our ability to keep patients at home. I'm, sort of speaking very much from a hospital center perspective, but if think about all the patients that are coming in and have short length of stays, what can we do to manage those patients not in the same physical setting, the same expensive settings that we're doing before? So ER, I think, is going to change significantly, shift in a lot of ambulatory procedures that is just going to be more rapid. And then in sort of the parts of the care around a hospital system, how can we use technology to treat patients in a less expensive and perhaps better infrastructure?
And Melissa, I know CVS Health has been a real leader here with a lot of low-cost, convenient assets. So can you talk a little bit about what your organization is doing?
So we've been doing things, I think, pretty much across our entire enterprise. I remember from the early days of the pandemic when the hospitals were so overwhelmed, and working with providers to lift, utilization management so we could move more patients, into long-term care settings or into rehab centers. So we were able to open up more hospital beds for the providers. We've also seen us able to use our assets, for example, to help move more infusions into the home, and again, out of the hospital setting, to try to lift the strain from the hospitals, but also to allow patients to who already have a frail immune system to stay home for treatment. And I think, you know, that's exactly the same trend line that we've seen around telemedicine, and you know, everything that state and the federal governments have been able to do to make telemedicine more accessible for patients and to lift some of the regulatory barriers that we have, I think has had a huge impact. So whether, you know, you're able to talk to your physician, I did one of my first telemedicine visits, quite frankly, during COVID. It was great, it was easy. So whether we're making it easier for patients to talk to their physician, or we're making it easier for patients to get their medications at home, you know, we wanted to make sure, particularly again in the early days, that folks who didn't really need to leave their homes didn't have to. And there actually were some regulatory impediments in both Medicaid and in Medicare that made it hard for us to do free home delivery. And so we had to work through a lot of that at the beginning of the pandemic. So just even something that seems so obvious, right, has had a huge change, I think, in the lives of millions of Americans. And then if you would have had me on this panel, you know, a year ago, I would never have been able to talk about, you know, an entire new testing regime that CVS Health is supporting. But as of today, we have now done over 6 million COVID tests. And so just that ability to be able to really bring into the community where people are, their ability to get a COVID test, I think has had a huge impact on just the everyday lives of Americans, and just be able to have that reach in neighborhoods where we've been able to go, I think has been an extraordinary change. And again, you know, ask me a year ago, I would have looked at you like you were crazy. But it's not something we were necessarily planning on, and certainly not at this scale.
So you both have touched on telemedicine, and obviously the government's, you know, really moved quickly to encourage access to that, and the private sector has as well. But what regulatory and reimbursement changes do you still need to make this permanent and to, you know, give yourselves more clarity in this business?
So I can start, and then others can fill in. You know, I think that there are a few of the relaxations that, you know, obviously would like to be made permanent. I think at a really high level, we want to make sure that patients are permitted to do telemedicine from their home when it's clinically appropriate, and that barriers on location, to the extent that they still might remain, you know, we think should be removed. We also want to make sure that there should not necessarily be requirements for a pre-existing relationship for a telemedicine visit. Like, I go back to my own example. It was a brand new physician for me. It was a sleep study. I always share my HIPAA information. It was a sleep study. It's not a physician that I already had a relationship with, but, you know, we had a 15-minute conversation at 8 a.m. Boom, we were done. It was great. So removing any kind of barriers in terms of having that pre-existing relationship, we think those are just two things that are, you know, pretty important going forward.
Maybe to add on to that, the licensure agreements changes that were made, and they were fairly restrictive, needing to be licensed in the state where a patient is. I had an instance of caring for someone, and they were in New Jersey. And if I'm not licensed in New Jersey as a New York physician, you know, in the prior, what I would think is sort of rather draconian measures, I couldn't see that patient technically. So I think licensure is probably one other element there that needs to be brought up. Frankly, you know, we went from at York-Presbyterian 1%, 2% of our visits being telehealth to 70 during the pandemic, and we're probably down to 20, 30% right now. 30% will probably settle at 20%. So when you think about practices, I think the question everybody's asking is, what's the reimbursement environment going to look like? Right now, the payment, there's parity. That's very unlikely to stand. The cost of that care is certainly less. And so where and how is the federal government, and really probably coming at that sort of level, going to take a look at reimbursement? They're going to have to be certainly aware that we're actually doing things that are additive to the healthcare system with telehealth, as opposed to rather substitutive rather than additive, and just, you know, having more visits and those visits not having value, but we're paying a lot of attention and focus on how those reimbursement changes may come to be, because I think they're inevitable. And just to state it fairly frankly, from a hospital system perspective, when a patient comes in, there are many other services that they partake in. There's testing, there's imaging, and that all goes away in a telehealth environment. And a lot of that is probably good for a patient, but some of that will need to remain coordinated. So we're paying close attention to that. I do not think that the parity will remain, but how the government thinks through that, I think, is going to be important in terms of uptake broadly, because that's the number one question I get from providers. Well, when's the other shoe going to drop on payment?
Professor Sparrow, do you have any thoughts on this, especially maybe the state licensure requirements, which are a challenge for specialists, for rural states, but broadly on these telehealth changes?
Let me unmute here. It's interesting, and I really enjoyed listening to both Deepa and Melissa's comments. I mean, I think the hospital industry and the pharmaceutical industry and the providers more generally are in the midst of a sort of rapid set of changes, as you talk about, some of which were underway before. I think the shift to outpatient, in hospital at home and telemedicine, et cetera, preceded COVID, but obviously was dramatically accelerated by COVID. Other shifts, I think, are a little unexpected. I mean, there was sort of a just-in-time approach in terms of supplies and PPE, et cetera. And so you had big battles over, competition for PPE and masks and testing, et cetera, early on. And I think hospitals and other providers now are trying to figure out in a sort of environment going forward where there'll be second waves and potentially other pandemics, exactly what kind of stockpiles they need to have and don't have. On the telehealth issue, I think two things I'd say. One, we in sort of HPM at Mailman are in the midst of working with NYP right now, and we're conducting an evaluation of many of the telehealth initiatives there. And I think we're already seeing some of the kind of dramatic changes that you're seeing and that are being reported by Deepa and Melissa. But at the same time, the regulatory environment and the reimbursement environment are absolutely key, as was pointed out. And I think, you've got a situation now in which a lot of this is happening at the state level. And so I think you're going to see very different dynamics play out in different states over the coming year and years. And I think it's just something to really watch pretty closely.
If I could ask you another question, Professor. The CARES Act was, I think, generally pretty successful and very much needed by many people in the industry. Do you think there's potential for a second CARES Act going forward? And on the other hand, so much of the money was unspent. Do you have any idea, why that was?
So a couple of things. First, in terms of the, let's just back up for 1 second, because when we're sort of talking about whether or not there could be a second CARES Act, we have to obviously talk a little bit about the election that we just had and where do we stand. So clearly, as of January 21st, we're going to have a new president. On the other hand, Congress would, regardless of what happens in Georgia, I mean, at this point, as you know, there are 50 Republican senators, 48 Democratic senators, and 2 to be determined in the state of Georgia. So we're either going to end up with a Republican, with Mitch McConnell continuing as the majority leader in the Senate because the Republicans win one of those 2 seats or both of those seats, or we're going to end up with the Democrats having the slimmest of slim majorities in the Senate. And I think the likelihood of gridlock on many issues is important to know and to think about the possibility of that happening. So when it comes to the CARES Act, you're right. I think there was a lot of money in the CARES Act that was enacted in late March that was distributed broadly. There's money left over. But I think there are 2 questions going forward. One is what's going to happen in the lame duck session that begins right now, and then what's going to happen post mid-January. In terms of the lame duck section, is there a possibility for an agreement between Mitch McConnell, Nancy Pelosi, and others? I think there's a decent chance of some sort of agreement coming out because both of them are in interesting places when it comes to leverage right now. Pelosi and the Democrats lost half a dozen seats or more than half, 6 to 10 seats. We're not quite sure in the House already. And so she doesn't quite have the leverage and she's getting some push, in terms of her own role as speaker going forward. So I think she has, a serious sort of incentive to try to work out a deal in the lame duck session. McConnell too has a incentive right now to try to work something out in the lame duck session because it's not, number one, 100% sure he's still going to have the gavel in late January. And number two, even if he has the gavel, he's got a couple of fewer members right now, and so it's a trickier position for him. So I think, number one, there's a chance we may see a new act in the lame duck session. If we don't, if they're not able to work something out, in the next couple of months, and we go into January, late January, February without a new stimulus bill, you're going to see a really tricky path in which the new Biden administration is going to be trying to sort of take together the money that's been left over, as you point out, from the prior program, and see what they could pull together in terms of a new program. And a lot there is going to depend on what happens, I think, with the pandemic more generally. We're in sort of entering sort of a second wave around the country right now. We may be entering a second wave relatively soon here in New York. If the sort of the battle is still sort of posed as public health versus the economy, I think it's going to be critical for President Biden to sort of try to break that bifurcation, try to argue that in order to solve the economic problems, we need to deal with the public health issues. And a key step of that is getting some sort of economic help through Congress. So I think the politics of this are going to be quite tricky going forward on the stimulus bill.
Okay, and then for Dr. Kumaraiah, can you talk about where the CARES Act benefited your organization the most and where you still have financial need?
Certainly. When you said, will there be another CARES Act? I'm sort of praying over here. Hospitals, come March 17th, I remember the day we shut down elective cases. That significantly changed, no surprise, the revenue coming into our hospital system. And I think thankfully at York-Presbyterian, we were able to, go from, sort of just in time to just in case on PPE and supplies and equipment and ventilators. And we spent mightily with very changed revenue construct. And CARES is critical for hospitals to be able to continue. I think it's fairly safe to say that most of the hospitals in New York will not turn a profit in 2020, and 2021 is also likely the case. We're not even checking break-even scenarios. So the ability to infuse revenue in whether it's the right thing or not, most of our P&Ls are fairly dependent on elective cases coming within the hospital structure. I will say it's been interesting the ramp back up of volume. We're probably 80-85% of where we would have been pre-pandemic, and there's just changes in consumer behavior. People are still concerned, right? Reasonably so. They want to defer. They're waiting a few more months, and if the numbers are any indication, we at New York Presbyterian is a 10 hospital system in the 5 boroughs of Manhattan and Westchester. We've been steadily at about 80 to 100 cases since June. And in 2 weeks, we've gone from 100 to 170 cases. It's not the same clip. Certainly, March, it's not exponential, but we are entering, I can fairly definitively say in New York, the second surge. And so we're in a kind of just returned to a financial situation that was more comfortable, and being able to maintain that is going to be important for providing care.
And just as a follow-up.
Oh, go ahead. I was just going to say, I was going to take a slightly more optimistic view of the potential for a package in the lame duck. For whatever reason, my cynicism has been washed away by the huge voter turnout, I guess, across the country, and just seeing so many Americans engaged and showing up, by mail or in person, I think has really been just phenomenal. But I do think there's potentially an opportunity for a package in the lame duck. I think that most of the caucus politics in the House are playing out below the speaker's level. There's some other leadership races going on where we're seeing a little bit more of that post-mortem dynamic playing out. There's always been a strong feeling in the House that they wanted an additional package. And, there were some frustrations that the negotiations were not successful prior to the election. But I do think there's some opportunity in lame duck. And if it doesn't work out in lame duck, the incoming President Biden will have enormous tools at his disposal once he's in place in terms of the CARES Act money that has not been distributed. And so the ability to actually get more money out to the states, to the providers, and to actually give further assistance, for example, in terms of testing, I think he's going to have that capability to do that. But don't forget, we're probably going to have an approved vaccine, at some point in December, early January. And for the new administration to come in and immediately also have to deal with those logistics, that's going to be challenging for them. But I think that we also have to keep in mind there are also going to be some other additional inputs or pressures into the healthcare system at large once the vaccine is approved and that distribution starts as well, particularly for healthcare workers who it's going to be so critical get vaccinated early so they can A, vaccinate others, and B, also continue to treat patients.
And if I could just follow up, what's been the impact on the deferral of elective procedures or non-emergency procedures on CVS Health? I know you've got different divisions within the company that have been impacted in different ways.
So, I mean, I think like many other, many insurers are experiencing the same situation. We're also seeing, we've also been seeing over the last several months an uptick in deferred procedures. So, I mean, we've started to see a change in that trend. Now, whether some of that starts to shift again with the increase in the virus across the country, I think, remains to be seen. But there are, we continue to see people coming for care. And we think it's really important to be reminding patients that you should not be ignoring your everyday care in this situation. And so, we've really been very proactive with our members and patients coming into our pharmacies and, sort of whichever aspect of our company, reminding them that keeping your health up in general is incredibly important in this time period. We've seen, for example, more people were showing getting their flu shots earlier than we have seen in past years. That's a good sign for everybody. And so I think we'll continue to see trends like that.
Okay, and Dr. Kumaraiah, can you estimate what level of your elective or non-emergency procedures have come back and maybe what areas have come back strongest or weakest?
I think at this point, each month has been sort of better than the last. And I think it's fair to say that October, in maybe half of our service lines, we were at pre-pandemic levels. And then the other half were sort of at 85 to 90%. Anything that one could consider as, slightly more elective is what's coming back slower. Endoscopies, outpatient endoscopies, some outpatient cath procedures, outpatient orthopedic procedures surprisingly have been, rather robust in coming back into the healthcare system. The visit volume returned, and as I said, we sort of saw the shift from 70% tele to about 30%. And, in New York specifically, not only was there a change in consumer behavior, there was a change in consumer site of living. We had a lot of people leaving the city, and we had a much more distributed care model where some of our non-Manhattan based locations saw activity much sooner than sort of in urban centers where our hospitals and clinics were.
Okay, and then a question for Professor Sparer. I guess, what are the first administrative actions you expect from the new administration?
That's a great question. And I mean, in the health arena, I think on day one, you're going to see some actions that are sort of like related to sort of reinserting our place sort of in the global environment, sort of the rejoining the Paris Climate Accord, sort of restoring our role in the World Health Organization. So I think sort of on a global scale, you're going to see those kind of things happen on day one. In terms of some of the kind of things we're talking about here, I think you can divide the new Biden administration's platform really into three different categories. There was sort of the big legislative proposals that they had, sort of a new federally administered public option, lowering the Medicare eligibility age from 65 to 60. I think those proposals in a divided government or in a 50-50 Senate, are sort of rather unlikely to be enacted legislatively. But you never know how it'll play out. But I think the road is very tough for those major kind of big legislative proposals. Then you have more sort of modest legislative proposals that I think the new administration is talking about. And we can get into these a little more if you want. And those are around sort of stabilizing the ACA in certain ways, increasing subsidies for the ACAs, some legislation around surprise billing, et cetera. And then you've got the things, as you point out, that they could do without going to Congress, and what they could do with the ACA almost immediately without going to Congress. And I think there, number one, there's going to be increased funding for marketing for the ACA exchanges and outreach for the ACA exchanges. I think they're going to try to limit the use of limited benefit plans under the ACA, and clearly a movement in that direction. I think they're going to try, when it comes to sort of the Medicaid expansion under the ACA, there've been a lot of waivers that states have used around work. I think they're going to change the regulation around public charge to try to increase immigrant eligibility for a program like Medicaid, which they could do through regulation. They can try to limit the use of work requirements in the Medicaid program. They could try to encourage states and incentivize. I mean, there's still 12 states that haven't enacted who adopted the Medicaid expansion under the ACA. I think they have a variety of tools to try to incentivize those states. And then for the other states, I think there's a variety of ways to use waivers, whereas the current administration, the Trump administration, has used Medicaid waivers both generally and under the ACA to try to encourage a scale back of public insurance through work requirements, public charge, et cetera. I think a Biden administration is going to try to use, particularly in divided government, the waiver process to try to encourage states to expand coverage and perhaps give some federal funding to the states to do that, given that the states are going to find themselves and do find themselves in a terrible fiscal position right now. So they're not going to be inclined to put a lot of new state money up. So I think the administrative actions you're going to see are around marketing, around enrollment, around benefit packages, around waivers. And then, of course, they'll take a very different position. They'll have the Justice Department immediately take different positions on everything from the ACA litigation that the Supreme Court just heard oral argument last week to a host of other litigation. And you're also going to see just a couple of more sort of quick administrative actions you're going to see. I think almost immediately you're going to see the Biden administration sort of scale back or eliminate the global gag rule, start to try to, which limits funding internationally to organizations that either provide or refer or counsel around reproductive health and abortions. You're going to try to see increased funding for organizations like Planned Parenthood here in the United States. So I think there's going to be a lot of actions they're going to try to take in the reproductive health arena as well. So I can keep going, but I think there's a fair number of things they can do without congressional action.
So if we do see increased enrollment in both Medicaid and the exchanges, I assume that's something that providers like York-Presbyterian would really favor.
Yeah, I mean, I'll say one thing, then I'll let Deepa say it. I mean, we've saw, from the mid 80s until 2017, whether you were talking about a President Reagan, Bush, Clinton, Obama, another President Bush, Medicaid enrollment in every one of those years went up, 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 up. From 2017 to 2019, for the first time in 50 years, for lots of reasons, Medicaid enrollment in this country went down by almost 4 million enrollees, over 3%. Since the pandemic, that decline has reversed, and you've seen Medicaid enrollment skyrocket across the country. And you did see in the CARES Act there was a 6.2% increase in federal financial participation for the states in the Medicaid program, and that's one of the big issues from a state perspective in a revived stimulus. But I think nationally an increase in Medicaid enrollment is going to have a major impact, and I'll let Deepa describe how it would impact New York-Presbyterian.
So, any increase in coverage is always seen favorably by providers wherever they may be. And hospitals, I think, would very much welcome increase in coverage, regardless of whether we're able to get something through that increases and expands Medicaid. I think there's certainly going to be just a shift in the payer mix nationally as a function of COVID. And, there's sort of two conversations I want to have about this. One is just, again, from a hospital and hospital finances perspective, and this is any part of the healthcare system, we're going to see a shift to Medicare and Medicaid amongst all of our payers. And a commentary that I think's been spoken a little bit about, but as we talk about technology and telehealth, there is some literature and burgeoning literature on how our use of engaging consumers and patients through technology is has variable uptake and perhaps success, I don't think we know, in different populations. And so we are very cognizant and spending a lot of time doing research, frankly, on how does telehealth, telemedicine, virtual constructs of care differentially impact different patient populations, different ethnicities? Is this going to actually increase disparity within the healthcare system? And just to note, I think our payer profile will look very different for the next 5, maybe even 8 years at this hospital system. And I would frankly say most hospital systems across America, and how do we think about technologies and how they interface with populations that already have so many other social determinants that they're dealing with, and add on another component, broadband access. In Queens, we've got 100 different languages in our patient population, and it's certainly not seamless to have an interpreter on a telehealth visit. So I wanted to bring it up because I think we're so excited. It's access, it's opening up, the ability of us to reach patients when patients are challenged, but that is something that we are spending a lot of focus on because it was one of our common feedback points from clinicians at the front line. Yes, I need to learn. Yes, I need to change my workflow. Yes, I need more technology, but some patients, it's very challenging for them to engage, and we need to be cognizant of thinking of ways the technology is meeting everybody's sort of access points.
And Melissa, do you agree with those changes in payer mix? And I know your organization's done a lot to try to address social determinants of health as well.
No, I think that Deepa raises a really good point, and I think that's one of the reasons why it's so important from our perspective to actually be in the community. Pharmacists continue to be one of the most, if not the most trusted healthcare provider. And so our ability to know what is happening in a community, what is happening in somebody's neighborhood, and to address the needs that we're seeing, I think is hugely important. We've taken a lot of different approaches on social determinants of health. In fact, we're making a huge investment in housing and building more affordable housing, because where you live and being able to live, have a home is so important in terms of how it affects the rest of your life. And so whether we're trying to manage care differently, whether we're trying to approach patients differently, or something as simple as helping somebody get a ramp built at their home so they can get in and out of their house, those kind of very tangible changes are so important in order to truly address social determinants of health. And then I think the other thing that we're also very focused on are racial disparities, in particular in terms of healthcare. We've made a very concentrated effort, for example, again, in our testing, to make sure that we're bringing testing to communities that might not otherwise easily have access to COVID testing. And what we have also learned is that you've got to approach communities where they are and with voices of integrity to that community in order to make sure that they're confident and comfortable in the healthcare that you're offering. And so I think all of these various threads really need to come together in order for us to make systemic changes.
So I've gotten a question from the audience that matches one of mine. There have been a lot of temporary add-on payments for COVID, whether it's waiving copays, whether it's a 20% extra payment in the hospital, or whether it's for testing, increasing it to $100. But some of that's temporary and potentially going to change back on January 1st. So I guess if you could, what changes would you prefer to keep, and what areas maybe do you need more reimbursement in?
Well, I think from our perspective, right now the public health emergency, I believe at the federal level runs through January 20th. And most of the relaxations and the emergency use authorizations are tied, as I believe, to the public health emergency. I think one of the very first things that you would see happen, for example, in a Biden administration, like day one, would be to extend the public health emergency, if it doesn't happen sooner. And I think while we are in a pandemic situation, I think continuing to make sure that testing and vaccinations are accessible and affordable to patients is just project number one. And so we would be very comfortable with those policies continuing.
Dr. Kumaraiah, do you agree?
I think we're very aligned in that way on those things. And again, I think whether it's federal stimulus or additional reimbursement for COVID patients, our population has changed significantly, that who we're caring for in the healthcare infrastructure, acutely. And I suspect it'll be interesting to see what this next surge is like. We're just caring for sicker patients with more comorbidities, and patients that have deferred care and then are coming in later in the stages of their illness. And so I think it will be critical. I think very much that the payment reform will have to model what happens with the pandemic. to be honest, and until we get to some sort of steady state of a healthcare, from a healthcare perspective.
And I would just add quickly here, and this goes back to something that Melissa said earlier and that I was trying to say earlier as well. I think there is a very decent chance that you're going to see during the lame duck session some sort of new CARES Act, new stimulus bill put through. I mean, there's going to be, a debate over exactly how it'll play out. I'd be surprised if on January 21st that Emergency Act hasn't already been increased, particularly with the pressure, I think, on Pelosi, with the pressure, I think, on McConnell, and with the second wave coming, and with the vaccine coming. There's nobody expects, I don't think anybody expects, even in the most optimistic of scenarios going forward, that anytime before, at the earliest, April, May, June of 2021, we're not going to have significant relief from the burden of the pandemic. I mean, that's sort of the earliest. Even if the vaccine is approved in December and begins to distribute in January, February, et cetera, it's going to take several months of concerted effort to distribute that appropriately, and it's going to take a national distribution process to do that. So I think there's just an incredibly strong likelihood you're going to see some legislation to sort of try to ease that transition.
I want to agree with that and just make one other comment on sort of the split government in some form that will inevitably be in play next year. I think it is to everybody's political benefit to actually do some legislative moves in the lame duck, because not only we will have a split House and a Senate, but McConnell will have got 20 seats that he's going to will be up for in the next cycle. And so it's not only that we'll be split, but we'll be facing sort of in the next 2-year election cycle, more races happening, and doing anything that's not sort of straight down the middle will be challenging for both sides. And so I do think that there will be activity. I sort of agree with Melissa and Michael, partly because of what 2 years from now may look like in terms of the races.
Now, one thing that we've been struggling with on a bipartisan basis is surprise medical billing. And both parties agree they want to do something, but the devil's in the details, and they can't decide, is it going to favor payers? Is it going to favor providers? Do you guys have any thoughts on, if that gets done either in the lame duck or next year?
So this is where the panel's going to split. We're no longer going to be aligned. I would think it is highly unlikely that something on surprise billing would happen in the lame duck. You do not yet have a political alignment. I think there's probably more consensus in the House of Representatives around legislation that's been put forward by the Education and Labor Committee and the Energy and Commerce Committee. I think the Ways and Means version is a little bit not making as much progress in the House. And several of the committees have also aligned with the Senate Health Committee. And so there's a lot of commonality of agreement around that, but there's also a lot of dissension around that. And I think there's the Senate in particular is still not quite aligned on surprise billing. Leader McConnell has traditionally been reluctant to move forward legislation where his conference is not in alignment. And his conference is not in alignment yet on surprise billing. Not to say that the House is all tied up, because it wouldn't be the House if it was all tied up. But so I don't really see that happening in the lame duck. There was one point this summer when the White House was trying to put forward, sort of a compromise version on surprise billing, and it really didn't get any real traction amongst Democrats, Republicans, providers, payers, House, or the Senate. So I think that's definitely an issue for next year. I think you could find common ground on surprise billing amongst providers and payers and employers, but not this lame duck.
Do any of our other panelists have thoughts on this?
No, I was just going to say, I don't think you're going to find any disagreement that you're not going to get an agreement on surprise billing in the lame duck. I mean, I think that is anything that happens in the lame duck, I think, is going to be around the stimulus and CARES and sort of COVID. I think the odds of a surprise billing, agreement in a new Biden administration, I think is fairly high because the administration is going to be under tremendous pressure to get a victory, to get something in the healthcare arena in that first several month period. As I said, I think the odds of a dramatic public option or the odds of lowering the Medicare eligibility age, extremely unlikely, extremely unlikely. And in that context, I think the push will be, all right, let's try to think about something more incremental, whether it's slightly higher subsidies through the ACA, whether it's, or surprise billing, I think is an area where, listen, it's not easy. If it was easy, the agreement would have happened 2 years ago. But I think you're going to see a lot of pressure on both sides to demonstrate at least some victories on both sides. As Deepa points out, there's another election coming up, just a couple of years later. And if it's complete gridlock and there's nothing that really happens on healthcare, I think it's tough for both sides to take that into the 2022 and then 2024 campaign. So I actually think the odds, if you were going to ask me one subject area where I think you might see sort of in a divided government situation, the potential for an incremental compromise piece of legislation, it would be around surprise billing.
And I will agree with both Michael and Melissa on that. I think one thing that was interesting from all the polling, though, is how much was either COVID or the economy, but was it healthcare that was, sort of driving voters? Was it, this wasn't a healthcare election. This is probably the most bipartisan issue to come forward. And if we do pass something, it'll be, again, in probably a hybrid version with, some threshold, some arbitration, somewhere in the middle of the various pieces of legislation that are going forward. But I think it's one of the more likely healthcare things, but I don't know that it's certain, because is this issue going to be the thing that rises to the top for the population? And certainly didn't seem to in the election. Obviously, it's hard when we're entering surge 2 of a pandemic to think about anything else but COVID.
The way I really kind of try to look at this and sort of what healthcare legislation and when, it's really, there's a kind of a cadence to the calendar here, right? So with the Supreme Court decision on the Texas v. California looming not until the late spring, like the term, not until the end of the Supreme Court term, it's hard to imagine anything big, whether you've got the votes or not. It's hard to imagine anything big happening until they know what the Supreme Court's going to do, right? If the election had turned out differently, there, potentially were different scenarios legislatively prior to the Supreme Court acting. But at this point, I think that kind of big discussion goes later. And I think, the professor has it right. The early discussion is all going to be about COVID, the economy, and making some quick, low-hanging fruit, if you will, regulatory changes that address a number of things that the Trump administration has done that they can roll back very easily through regulation. Just withdrawing the public charge rule is the obvious thing. That's just one example. And so I think, the way I've talked to my company about thinking about it is really in terms of the calendar and the timeline. Some things they're going to be first and foremost, and then later on, we're going to see other conversations and other policy debates.
Yeah, I think that's exactly right. I think the only slight caveat I would make to that, and it's really just a slight caveat, is I think at this point, even before oral argument, I think the odds were strongly in favor. Even with the 3 Trump appointees to the Supreme Court, the odds, at least from my perspective, were highly in favor of the ACA writ large surviving this challenge. I think the likelihood that a Supreme Court, even with an Amy Coney Barrett, was going to sever an individual mandate was very high. And then I think oral argument sort of, you even had a Supreme Court Justice Alito basically saying, well, doesn't the ACA seem to have survived pretty well the last couple of years with the individual mandate? And you had statements by Kavanaugh and Roberts. So I think all of the tea leaves, both before and certainly after, despite the Democratic Party's effort to sort of paint the Barrett nomination as, potentially leading to the death knell of the ACA, I think that was more political than sort of likely legal. And then the other caveat that I throw in is presidents know, and Biden knows, that they basically have a year to get anything big done. By the time they get into year 2 of their administration, they're already in the midterm elections, and it's very tough. I mean, that's why, that's in part one of the reasons that Bill Clinton had big trouble back in the early 90s. He didn't do it in year 1. And that's why Obama made sort of comprehensive health reform his #1 domestic priority in his first year. So I think to the extent that Biden needs to think about what can I do in year 1, it may not be in healthcare, or it may, if it's in healthcare, it may just be stimulus and COVID related, but it may not be anything else. It may be around climate change, it may be around immigration, it may be around energy policy. You know, I'm not sure that healthcare generally is going to sort of rise to sort of the year one level of sort of major legislation. I think had the Democrats picked up several seats in the Senate and sort of taken over the Senate, not just a 50-50, but had they had sort of a 53, 54, 55 vote lead where they thought they could truly use budget reconciliation in a pretty easy way to get through a potential public option or so forth, then I think you might have seen that as a year one priority. I just don't think you're going to see that as a year one. So then if the question is, what can we do in healthcare that's going to be sort of a second level activity, then you're into the surprise billing type things, which I think could happen almost at any point during the first year.
Okay. Now, one question we got from the audience is for the two provider organizations here. The payer mix that we talked about towards Medicare and Medicaid generally means lower reimbursement and probably financial pressure on at least some aspects of the organization. So how are you planning to cope with that over the next several years?
So that is absolutely true. When you look at the payer mix and what we're anticipating, we've been thinking through, again, it's probably just a continuation of our journey of how can we be more consumer friendly and seamless to the patient, so that we aren't adding anything to our own cost structure. Hospitals will have to significantly change their cost structures, their built-in cost structures. There will, likely be people changes, right? People are the biggest part of most provider organizations, and thinking about how we can use technology to improve back office operations and other things, because the revenue side is going to be challenging for the next 5 to 10 years. Again, 5 years probably, how to bring care to the communities. Melissa, as you said, pushing what we can out into primary care, into our clinics. How do we ensure that people are coming in earlier for their care, for their preventative care? It's all the things that we need to do, again, accelerated, and we will have to look at our cost infrastructure. And I anticipate provider organizations will have to change that notably.
Yeah, and I think from our perspective, where we're really centered is trying to find ways to provide care more efficiently, more simply, and to improve healthcare outcomes. And I don't think that approach doesn't change going forward. It was a lot of the thinking behind our acquisition of Aetna. It's all about the transformation that our company leadership has been leading within CVS Health, across all of our lines. And so, it's not necessarily that, all of a sudden we're looking at, some huge change. I mean, this is who we are, and this is how we adapt. And it's really, from our perspective, it's what we're trying to provide, whether we're trying to provide, payors options, what we're offering to our, to our members and to employers and state health plans. It's all about trying to keep things more simple, efficient, and improving healthcare outcomes.
And that focus on outcomes brings us into the last topic we wanted to cover, which is value-based care. And I think that's moved a little bit slowly under the current administration, but generally has bipartisan support. So I guess just could you give a few examples of where you're doing value-based care today and where you'd like to see it go?
So from a healthcare system perspective, we're part of an MSSP ACO and just a little bit on York-Presbyterian structure. We're a hospital system with 4 medical groups, and we partner with 2 academic medical centers. So both Columbia Doctors and Weill Cornell Medicine are certainly looking at value-based payments within their commercial contracts. And we'll probably keep, we're very much looking at, I'd say in New York, that value-based market has perhaps moved slower than other parts of the country. Whether that comes through legislation or not, we are thinking of our infrastructure such that it's set up that we're thinking about episodes of care. So however we're building clinical programs, that's in our mindset, and we'll continue to do that. I'd be curious, particularly with all of our initial discussions about telehealth, how telehealth gets woven into any future VBP discussions, because I think it's going to be important. It is I think can add value if done correctly and in sort of the right episodes and instances of a care stream and chronic care management and otherwise. So I think we're we're thinking about technologies. We're part of a Medicare ACO. We're continuing to do commercial contracting. I think it's still going to be slow in the New York City, New York metro market relative to different parts of the country for a variety of complex reasons. And I think perhaps there were, in the existing value-based care programs, it was sort of slow discussion of whether they were continue, whether they were going to be mandatory, even within the CJR, the Comprehensive Joint Replacement Program. Was it going to happen? It sort of kept getting delayed, and then COVID. I think some of that timeline will pick up. So the existing programs, and again, sort of episodes-based programs around radiation oncology, end-stage renal disease, you'll start to see those happen at a much, I think, at a faster clip. Again, I'll put all of this preface pending pandemic.
And Melissa, any examples of what you're doing or what you'd like to be doing in the future?
Well, we're trying to create true partnerships with providers that, align incentives for quite high quality whole person care, as well as providing support services that help them achieve better outcomes. And so we have, a number of different examples, sort of across the enterprise. One area in particular, we'd also like to do more on value-based arrangements is around some of the higher cost drugs. And there are some regulatory impediments to that sort of prevent us truly taking advantage of all the tools that we would like. But I think that particularly as we're looking at some of the more expensive gene therapies, et cetera, trying to do value-based arrangements in those areas is also going to be equally important.
So I would just sort of add here, I think, both Melissa and Deepa's comments are right on. This is really the whole question of value-based payment is sort of this interesting area in which you have sort of this mix of sort of the policy, the macro policy environment, and the market sort of crossing each other. Clearly, I think you've seen in the last few years, CMMI and sort of federal officials have been a bit slower. I mean, nobody has come out saying, we're against value-based payment. I mean, that's like saying you're against, I don't know,
apple pie.
Yeah, we came up with the same example there. But I think there has not been sort of a rapid effort from a macro policy level to sort of, steer the ship, sort of quickly help and help the market sort of navigate its way through that, whether it's mandatory versus voluntary, et cetera, et cetera. So there's been slow incremental expansion, but really, I think, disappointing advances. But at the same time, you've got the marketplace, you've got the CVSs and the Uniteds and, and et cetera, basically from a market perspective saying this is, and the providers, the provider community itself basically saying these are directions that we want to go in. We just need a little bit of extra flexibility, perhaps from regulatory oversight, but we can sort of, and in fact, if you look at, when you look at the ACA and its efforts around value-based payment, that was an area in which I think the public sector was following the private sector. I mean, they were sort of building off of initiatives that had already been underway in the private sector and in the commercial insurance world, et cetera, around pay for performance and value-based payment, et cetera. So you've got a little bit of this sort of mixed public-private activity going on here. And I think you are likely to see an increase on both sides going forward. And I would also sort of pick up on what Melissa was saying earlier about social determinants here and sort of trying to sort of build in, I think there's a lot of effort to try to, build in efforts to sort of think about different kinds of outcomes and different kind of metrics to evaluate, success and to evaluate successful performance. And I think you're going to see potentially some of the lines blur between insurance and social service delivery. And to the extent that regulators permit that, permit Medicaid or permit other insurers to pay for certain kind of social services, then you'll see again, I think in that area as well, an effort to use value-based payment to try to encourage providers to, to sort of take care of the population of the community in which they exist, as opposed to say simply the individuals who show up in the emergency room.
Well, I'll just make one final comment before turning it back over to Bunny. I think the kidney dialysis program was very well designed, using mostly carrots for the industry to try to encourage more transplants, more home dialysis. I know CVS is working on a machine in a year or two for that. And I think that's a program that is going to get a lot of industry buy-in, and I hope it's successful down the road. But now I think we'll turn it over to Bunny for some closing remarks.
All right, well, thank you. I've been texting you guys while you've been on. This is one of the most informative and interactive and interesting policy panels I have heard in a very long time. Thank you all. It was incredibly valuable. And now you get the rest of your day back. So we've got, thanks again. We've got one more panel coming up in 5 minutes, 11:05 on virtual care. In the interim, get coffee, whatever, do your thing. But we have a panel that we're going to drop in chat. So if you want to take our Google or G panel, there are 2 questions, and then we will share them during the 11:05 panel. So thanks again to our wonderful policy gurus, and I'll see you other guys in 5 minutes. Thanks.
Thanks for having us.
Thank you
Bye.
very much.
Thank you.
Bye-bye.